So now we get to hear from some people who were there when all this happened. And I want to introduce Dr. Glenn Forbes, who is a graduate of the University of Notre Dame and Yale Medical School. He began working at the clinic in 1973. Throughout his career, he served as chair of the Department of Radiology, CEO of the Franciscan Scamp Healthcare in La Crosse, and vice chair of the Mayo Clinic Rochester Board of Governors and CEO of Mayo Clinic Rochester before retiring in 2009. He has been a member of numerous other societies, including a term as president of the American Society of Neuroradiology. Dr. Forbes.
Well, thank you, Cynthia. About 30 years ago, when I was chair of our Department of Radiology, I got up out of my chair at the desk and ambled down the hall mid-morning for my second cup of coffee down to the staff room. And I ran into one of our senior staff radiologists, a fellow named Harley Carlson. Some might actually know him. He's passed now. But he was a nationally known, well-respected radiologist, very calm, friendly, very confident individual. Something was different this morning. Harley was kind of fretting and a little nervous, very uncharacteristic. So I walked over and I said, Harley, I said, are you okay? What's going on? And he said, well, I'm a little nervous. I'm not sure how I'm going to do this. He said, I have to give a presentation and I'm just trying to figure out how to put it together. I said, Harley, you got to be kidding. He's been president of national societies. I said, you've given refresher courses numerous times. I said, what could possibly be causing you any anxiety about this? And Harley said, well, I'm from a small town in Montana. He said, our high school graduating class was about 40. And he said, they've invited me back to give the commencement address for our high school graduating class. And he said, I know I'm going to have their attention for about 2 or 3 minutes. And then I'm off. He said, so how do I convey all of this in just 2 or 3 minutes, what I really have to tell them? So, I did what I think any one of us in the auditorium here would do. I walked over to him, put my hand on his shoulder and looked him straight in the eye. And I said, Harley, good luck. So this is a little bit of my Harley moment. Cynthia called. There's only about 2 of us, I think, and we'll hear from the other one in a few minutes, who were actually there working with this first scanner. And Cynthia says, tell us what it was like. Give us the atmosphere, not the facts, but a little bit of what was going on at that time. So how do we do this? I'd suggest come back with me. Let's get on that time travel train and let's go back 10 years, 15 years, 20 years. Look out the window and there's no social media, nothing to use to share our thoughts or exciting ideas. Go back 25 years, 30 years. Suddenly our personal cell phone disappears. There's no internet. Now let's go back 35, 40 years. Personal computers disappear from your desk. The only information was in books up on the shelf. 45, 50 years, the dawn of computerized imaging. It was a different world, and radiology, frankly, was a different place. It was kind of a quiet, more sedate type of atmosphere. Radiology was sort of a second tier area in healthcare, if you will. Using a metaphor of the game of patient care, the radiologists were kind of carrying water on the sidelines, while the principal players were the surgeons and internists on the field, making all the diagnoses and treatments and what have you. Sometimes half jokingly, radiologists would be asked, are you real doctors? Or if you were at the proverbial Thanksgiving table, I think Aunt Louise would ask you, well, what are you doing with your new medical degree now, son? And Uncle Ben would stab his turkey with his fork and look up and snort, well, you're just in the basement of the hospital looking at pictures, aren't you? That's all. So it was a different kind of world. Some folks even would be going into the field from various areas, maybe finding their way into radiology, maybe having spent a year or two somewhere else. It was just a different world. I'm not saying that we were unhappy or it was bad. It was just a quiet, more sedate type of atmosphere. It was somewhat of a backwater of medical care. And we were like, I'd say, sitting on the side of a quiet mountainside with a volcano underneath us, just about ready to erupt and change the surrounding environment forever. But we weren't aware of it. But when it occurred, we responded and everybody became energized and participated in all of this particular change. Now, you've seen part of the film. These three individuals up here were key people for positioning Mayo at the forefront of the development of CT and imaging. They're all gone now. I knew each one of them fairly well. They were my teachers. They were my mentors. And in later years, they were, in a big brother sort of fashion, my friends. The first one is over there on the upper right. You saw his picture, Colin Holman. He was at the time a nationally recognized neuroradiologist. He was actually one of the 12 founding members of the American Society of Neuroradiology, which defined the specialty. He was a very quiet, very polite fellow. Some people would say, maybe a little fussy, but, he thought other people were a little fussy too. So that kind of balanced out. He was very dedicated to patient care. He was dedicated to Mayo. But most importantly, when the time came for an opportunity to see and act on change, he acted courageously and very decisively. So you saw the history in the movie. And you saw how at that external meeting, he'd met with one of the British clinicians. And in a single brief time of a meeting, he came to the conclusion that this new technique could be a real game changer. And he looked and he thought, this could really transform things in diagnostic medicine if it worked. So he took those few images and some of the information and brought it back with the attitude that we really have to look at this and really place Mayo in the forefront of all this change. He was very decisive about that. At that time, he had some meetings. You heard a little bit of the meetings. Now, over the years, there's been various interpretations of those meetings. Some people felt they took a little while to figure out what they were looking at. But once they looked at it, most people said, this is really very, very different. This could have some really transformational change in what's going on. Now, out of those meetings, regardless of how they happened, two outcomes occurred that everybody agreed on. One outcome was that they could say John Hodgson, he was better known as Jack Hodgson in his day, joined the effort to get the institutional support. The second outcome was that Bud Baker became the key driver for the acquisition of that first unit. So all three at that period of time were really rolling the dice with their careers, their attitude. There's sometimes, I think we all know, you're confronted occasionally with that opportunity where you see this is something that could really change things. You put all the chips to the table or you don't. You roll the dice. If you lose, you fail. But if you win big and you change things. And all three took that conviction to say, this we really have to get involved with. And more than that, we have to do it fast and we have to do it very decisively. And we don't have time for a lot of deliberation about it if we're going to lead this change, because this is really a big change. That's all three. Now, at that time, Jack Hodgson was chair of the department and also was a member of the board of governors at Mayo. So he was kind of like the Matt Kallstrom of his day. He wasn't a researcher and he wasn't really a scientist, but he knew the administrative ins and outs of the institution. And he understood his people and believed in his people. And he was convinced. What happened, the details of how it happened are somewhat lost in the kind of shadows of time, but we do know the outcome. The Board of Governors approved the acquisition of a relatively untested and untried research unit. And they did it without, as you saw in the movie, any normal review process of the clinical practice committee, the finance committee. In those days, you'd get affiliated department support. And they proved it to the tune of, as you saw, about $250,000, which must be 2 to 3 million, I think, in today's dollars. That is almost unprecedented. I've had the chance to work with and on all of those committees, and to have something bypass those, go to the board and have it approved is just almost unprecedented. I heard once Jack being asked how that actually happened, and his answer was simply the idea sold itself. Maybe that's true, but I sometimes suspect there must have been more to that. And I think one of the unsung group of heroes in this whole story actually is the Board of Governors at that time of the Mayo Clinic that saw this idea, became convinced that it was a transformational move, and they took the risk to go ahead and acquire this unit and put it in. That's a big step. And I think none of that would have happened, obviously, without their support. So then the saga changes to Hillier Baker, who, as the movie said, was better known really by both his friends and any detractors as Bud, simply Bud. Now, this is interesting. Movies professionally can't really get totally into some of the human aspects of all of this, but Bud was probably one of the more colorful, arguably one of the more controversial, and one of the more interesting of the three. He was an interesting fellow. He was tough. He saw things black and white, and he had his own way of doing things, but he was sharp. And almost invariably, he was on the right course. He was on the right track. Bud became the driver for the acquisition of this unit, and that was a good move. But he was, everybody had to kind of work with that and say, how's this going to go? Quick little anecdote. I had been on staff, I forgot, a year, 2, 3 or something. I approached Bud once and said, Bud, I think there's a simpler and easier way of doing something. This is a true story. He actually looked at me and said, I think you need to go home and reflect on whether you really have what it takes to be a neuroradiologist at the Mayo Clinic. Well, I would have wilted, I think, a few years before that. But at the time, I had been just enough confidence. I said, Bud, that's not the answer. I don't think that's it. I think there really is an easier and simpler way of doing things. And Bud would look and say, well, kind of snort, well, if you think so, then just go and do it. And then he'd kind of walk off. There was no better person that you could ever hand a manuscript that you were about to submit to, because he'd tear it up, he'd edit it, and then he'd suggest rewrites and hand it back to you 2 times better than whatever you gave him. He had a laser sharp focus on what to do. He was the perfect person to take that next step. And as you saw in the movie, he went over to London, and his own personal memoirs say that he spent about 5 or 7 relatively sleepless nights. And knowing Bud, I suspect that they were really sleepless nights. And his own memory was that he really just dove into it. And knowing Bud, he looked at the concepts, he studied the technology as best he would understand them. He talked to the people who put together. He talked to the people who were using it. He went over all the data. He absolutely tore into everything. And he came to the conclusion as well that, yep, this is the real deal. And so as authorized, he put the order down, and the rest, I think, is almost history. After a relatively uneventful change and travel over here, he actually set up the Mayo style of the exam. It was usually about 8 slices, 5 to 6 minutes acquisition, 45-minute type exam. He worked with a senior technician named Daryl Holtz, who I believe is with us. In fact, somebody told me he might be here. Daryl, raise your hand. because of the volume of what happened, that man right in the back row, Daryl, was the most knowledgeable person in the world about how to operate a CT scanner. Daryl, shake your head and accept it. So Daryl was in the picture in the movie there for several pictures we saw. Well, the rest is history, as we said, and as Cynthia will tell you, the first patient actually here in America was scanned in mid-June of 1973. Shortly after that, more and more patients came and the volcano had erupted. Things would never be the same. The changes were immediate and they were amazing. Now, in those days, I was still a fellow. And in the culture of the time, fellows weren't expected to ask questions or learn directly. You were supposed to kind of learn by inference of what was going on. So we would sit in the back row of the conference room, which is down the hall in the Mayo building there, watching the staff be so excited up front, literally looking at things. Wow, look at this. This looks like a slice of bread. Well, boy, if you just absolutely try to configure in your mind's eye and put them together, it's like a three-dimensional appearance as you're looking at the body. This is amazing. And someone like me, we'd sit in the back and I'd wonder out loud, well, why do those images look so grainy and they look like sort of a distorted weather map? So of course I'd get jabbed by my friend Bill on the right side and say, Forbes, you idiot. That's because there's only 80 squares they call pixels that are actually contributing to make up the image. So then I'd say, well, yeah, but why is the CSF dark? And why is blood sometimes dark and sometimes white? And how are these changes? And my friend Jane next to me on the other side would look and say, Glenn, I can't believe they let you into this program. That's because of variability in X-ray absorption. We were all learning these things as it went on. What about those streaks? They all seem to happen at interfaces where you have different tissue characteristics. We'll call them bony artifacts or streak artifacts. What about something that doesn't look like, well, we'll call that partial volume averaging. I mean, the list went on and on. There was no format for what we were looking at to try and interpret the images. Everything was intuitively looked at. We just tried to understand what was happening. But it was an exciting time, and everybody recognized that things were changing. They were very, very different. So we knew that this was going to be, quote, big stuff. Now, I'm going to categorize the impact changes in 4 categories briefly. The first category was that the scanning, new study, if you will, changed the diagnostic workup in a whole bunch of different ways. You saw in the movie. The first one was pneumoencephalography. That was one of 2 invasive exams at the time. That disappeared almost immediately. There's a little bit of a holdout for about 2 or 3 years because we were using it to look at what's called the empty sella syndrome, defects in the diaphragmatic sella. 2 of our surgeons were doing transsphenoidal pituitary microadenoma surgery, and that exceeded the limits of the scanner at the time. But even after about 2 or 3 years, that disappeared. I performed the last pneumoencephalogram here, and I think it was probably around 1977, maybe 1978. And that was good riddance. As you saw a little bit in the movie, and they kind of almost color coded that a little bit, it was a nasty exam. We would extract 10, 20, 30 cc's of CSF, put in fractional air, patients strapped in a chair like an astronaut in training, somersaulted backwards and forwards to distribute the air while pictures are being taken. The patient's vomiting, they're in pain, anesthesia is there, monitoring with a fretful look that there wouldn't be tonsillar herniation. I mean, that was a bad exam. So good riddance to that. That was immediate. The other invasive technique, cerebral angiography, was altered. We used to do bilateral carotids for looking at intracranial sub and epidural hematomas. That disappeared. Mass displacements with cortical displacement, that pretty much disappeared fairly rapidly. Angiography persisted for a study of vascular studies, much as it is today. Skull films, as you saw, never really told us that much, so that disappeared. One of the big changes, though, was on the clinical side. because after hours of examination and careful deduction and inference, there must be a problem here. You could suddenly match that with a computerized image in a few minutes that would show you a lesion, its location, and many of its characteristics. So you can imagine that changed things fairly rapidly. So the whole format of approaching neurologic disease changed. The second category that we recognized was that there were suddenly so-called new elements of pathology that suddenly came to the table. These were things that were only known by pathologists at autopsy or maybe open heart or open head surgery. But now you can actually see things like giant thrombosed aneurysms, thrombosed AVMs, large areas of demyelination, pseudotumors, arachnoid cysts, certain types of teratomas and the like. So these are new entities that now became very, very clear in cross-sectional imaging. The third impact was one of more of a social, psychological type of thing. It really did change the role of radiology at the time. Suddenly in that metaphor, the radiologist was taken from the sidelines and thrust onto the middle part of the field, playing with the first string, making calls and diagnosis and making calls and triage of treatments. And surgeons and internists alike and whatever were amazed. Who are these folks coming out of the radiology department, suddenly dictating with new information about where things should go, how they should be studied, how treatment modalities ought to be administered? It really was a change. And if you think about it, such transformative change in a social area sometimes is a delicate matter, has to be handled the right way. I think we probably handled much of it the right way, and maybe some of it we probably could have done better. But clearly there was a change in the role of imaging in the diagnosis and the treatment of patients. So now when you went next year back to the proverbial Thanksgiving table and Aunt Louise asked you what you're doing, you'd say, well, actually I'm pressing the forefront of medicine and using computer-assisted analysis and looking at new diseases, treading where no one had ever gone before, and discovering new things and changing the whole world of medicine and saving the world while we're doing it. Silence at the table, even I think cousin Lonnie, who everybody in the family knew was the dimwit of the family, would look over and say, dude, that's cool. That's really good. So things really changed. We all knew that radiology was now in a different role. This required more out of the people who were in the field. It required a deeper understanding of all those diagnostic possibilities and options. It required a deeper understanding of what the treatment modalities might be. It actually opened up the gate where a number of very energetic young folks were now scampering into the field of imaging. It changed the whole educational program. Suddenly radiology was a great thing to do. People wanted to get involved in it. It really changed everything dramatically. And I think it led to pretty much where we are today with the field. We knew it was going to upset and turn things upside down. Now, at the time, there was no fear about things. It wasn't like anybody worried about AI chatbots, taking over human civilization or something like that. There was, however, a feeling that this was going to turn diagnosis upside down. There was that recognition, but it was accepted in a very exciting way. And people felt this is what we need to do to move things forward. So we went forward. Now, the fourth category that I'll mention is that there was a significant impact on the regulatory and business side, the impact of CT. Suddenly, just about every hospital in the country decided they needed one of these CT scanners. There was a large trek of visitors to Mayo, as the movie implied. And for several years, people are coming from every place in the country and all over the world, coming here to see what was going on, going back. It was a tough time because the good side of this was technically there were leaps and bounds of changes. Alterations were being made almost monthly. There was a backlog of getting scanners. And there was a time in the 1970s where a hospital could put down $500,000 to $1 million wait 6 to 9 months for their prize scanner, get it and find out that it lacks some of the latest changes or might even have been considered obsolete. So this was a very tumultuous time. The government tried to step in with regulatory issues like certificate of need based on population distributions and sizes and whatever. To be honest with you, that worked a little, but not very much. And pretty soon that was overridden by market forces. And so the tumultuous time went on for years. When it started to have some economic equilibrium, about 10 years later, as we all know, MR came along and sort of started the cycle over again. And I think to some extent today, we still work with that issue of how to deal with cost-effective analysis. And it certainly started with a real firestorm back in the early and mid 70s. Now, I'm going to hand it over before I do to my good friend and colleague, Pat Sheedy, who's going to tell us a little bit about how this migrated from the head down to the body. But there's one last thought that I'd like to leave us with all here. I think it's really key, and I think it's part of our legacy, little piece of history. Our unit that you saw there, that's right down the hall, was the first unit of 3 of that model of EMI CT scanners. The second one, about a month or 2 afterwards, was placed at Mass General. And the third one was placed at Duke about a few months after that. Now, sometime about 20 years afterwards, this is in the 1990s, there was a bit of a renewed interest in the history and exhibition of these units. People wanted to know a little bit more about what things looked like, and we even had offers about transporting the unit elsewhere for medical exhibitions and so on and so forth. We had worked very hard to preserve that unit. We had scampered just a little bit an arm's length ahead of the bean counters who had wrenches and hacksaws that wanted to scrap the unit. And we literally moved the unit from place to place. It never left Rochester, but it was on and off campus. It was in the Damon Museum for a while. Then we moved it to the Fullerton storage area. Then we brought it back. It was on a patient area on the 3rd floor, finally on the 2nd floor where it is. So it was moved around. We contacted Duke. Duke at the time had admitted that they thought they had probably scrapped their unit. Mass General was never quite clear. They weren't sure whether they had stored it or not or had it, but we never really saw it in exhibition. And as I stand here today, I'm fairly certain, until proved otherwise, that the sole surviving model of CT is the unit that we have right down the hall. And that's appropriate because it was the first unit. So I would suggest don't let anyone obscure that story or that part of things. The first CT scanner in America is the one that we have right here down the hall that was used at Mayo, implemented in mid-June of 1973. So that's something of a legacy that I would ask people to think about. And think about the energy and the commitment that some of the forebears really made to bring that to fruition, make it happen. And as you push that envelope forward, I think all of us who've had any part of it are wishing everybody well, but we're now cheering from the back bleachers. So go forward and make it happen. And Cynthia, thanks for reminding us all of it. Thanks.